Hi, my name is Christopher Voscopoulos, and for those of you that might not know me, I am one of your anesthesiologists, but I am also a board-certified neurocritical care doctor who continues to practice. And I have this opportunity today to discuss with you the care of the patient with an external ventricular drain. And since we will be rolling out the placement of EVDs at Lawrence General Hospital, we thought that this would be a good opportunity to put out this video um, to familiarize everyone with EVDs. So to that end, let's jump right into it. So the objectives, we're going to define what an EVD is. We're going to list indications for EVDs. We're going to describe how to use an EVD to guide clinical care. We'll talk about complications from EVDs that you should be aware of. So the first thing to discuss is this really famous topic of the Monroe-Kelly doctrine. And it's not a difficult topic to understand by any means whatsoever. So as we all know, our skull is ossified. It's rigid. It cannot expand. It cannot contract. And so anything within our head, if it expands, it's going to increase pressure within our head, again, because the skull cannot expand out. So what is within our skull? Well, in red here, the majority of the matter is brain, approximately 80%. And then we have cerebrospinal fluid, and then intracranial blood, both arterial and venous, and they make up each, again, approximately 10% each. And so recall that we want to maintain normal pressure within the brain, within the skull, I should say. And so if one of those entities increases, say you have a brain tumor, well, then you're going to have to decrease cerebrospinal fluid or intracranial blood to maintain a normal pressure. So keep that in mind. So the first question we have here is what is a normal intracranial pressure? And it's somewhere between 7 and 15 millimeters of mercury. So by definition, greater than 15 millimeters of mercury is an elevated ICP. When it starts to get 20, we start to get really concerned about elevated ICP. When it's greater than 25, we really have to start to institute aggressive treatment to lower it. So along with the concept here of intracranial pressure, we have the concept of cerebral perfusion pressure. And so your ICP is a pressure here, and your heart's going to beat blood. And so as the heart beats blood and you have a blood pressure and the blood comes up to the head here, a small amount of that pressure coming up, the blood coming up to your brain, is going to be reduced by the ICP. And the net result of it is the cerebral perfusion pressure here. And the equation is very simple, right? It's MAP, the blood pressure coming up, minus the ICP. And this is an important number to keep in mind. A normal ICP is approximately 60 to 100. So intracranial pressure, right? The definition, it's an pressure within your skull. And so factors that affect ICP or causes of increased ICP are, again, any of the things that I just mentioned: an increase in brain matter, an increase in blood, an increase in cerebrospinal fluid. And so as you can see here as listed, say if you have an intracranial mass, a tumor or an abscess, or what if you had a large infarct? And then with that large infarct, you started to swell that area of infarct and it became very edematous. That can give rise to that too. Or maybe you have an inflammatory process in the brain, say encephalitis, that is also drawing in a lot of water. Or maybe you have an obstruction in your cerebrospinal fluid flow, or maybe an increased production of cerebrospinal flow. Or instead of coming in with an ischemic stroke, perhaps maybe the patient comes in with a hemorrhagic stroke. And so now they have an increase in blood volume. But another thing, and the last item that's mentioned here, and it's important to note, is that you can have obstruction of venous flow. So if you have, say, an endotracheal tube in and you put straps around the neck and they're very tight, well, you can compress the jugular veins here and you can increase pressure up into the brain. And that's something really important to keep in mind in this patient population. So we're going to discuss placement of the EVD. So here's just a quick diagram showing that you would have to, in order to place an EVD, get through the scalp, get through the skull, get through the brain matter, And we're going to place the EVDs in the lateral ventricle. By convention, we usually place it on the right side, unless if there's a reason to put it on the left. And here you can see here one of the lateral ventricles. You can then see the third ventricle and then the fourth ventricle down here. Again, we're going to place it in the lateral ventricle, usually on the right. And so the process then would involve a small incision to get through the skin, and then to use a burr hole device. Now, this burr hole device will apply pressure and will start to screw through the skull. And then the second you reach negative pressure, or when you reach the dura, when there's a loss of pressure, it stops to prevent the device from going into the dura or into the brain. And then here we would place our particular catheter again into the lateral ventricle, usually on the right side. Here is a little more detail. What you would do here is you would identify the mid-pupillary line. You go back approximately 10 centimeters. This is called Koch's point. And this is where you'd make your incision. And then when you're going to direct the placement of the EVD, you direct it both towards the nasion, right here between the eyes, and towards the tragus at the same time to get into the lateral ventricle. And then upon placement, this is what it'll look like on the outside, where it'll be heavily sutured because we don't want this to move. And what about imaging? Well, if you look at imaging, you can see that there are multiple holes to the EVD. And this is the concept here I wanted to show you in this particular image. So you could see these multiple holes if you get it on the right angle. So what about complications from an EVD placement? Well, you're placing something in the brain, so you could have bleeding. And bleeding could occur in approximately 30% of placements, but clinically significant bleeding is much less common. And if you had bleeding along the tract, this is approximately what it would look like here. Now, you could have misplacement of the EVD where you could not get it into, or it got dislodged out of the ventricle. Or you can have occlusion of the EVD, say with thick fibrin clots in it, or possibly even fracture of the EVD. You could possibly have infection of the EVD. And infection is strongly correlated with how long you're going to leave the EVD in. So say if it's left in for more than 7 days or so, the risk of infection starts to dramatically increase. And this infection could progress to ventriculitis, meningitis, and possible abscess. Or you could have neurological complications. Say if you place the EVD too deep, you can go into the reticular activating system and cause coma. You can have a post-dural puncture headache, similar to what we have in anesthesia when we do epidurals. Or you can have over drainage of CSF, a topic that we'll talk about in some detail. So why are we going to place the EVD? Well, we're going to place the EVD, say, for some clinical indications. If someone has traumatic brain injury and they have swelling of the brain and we want to reduce brain swelling, or we want to track their increased intracranial pressures, their ICPs. Say someone has subarachnoid hemorrhage, or say bleeding into a ventricle, and we want to drain that bleeding. If someone has hydrocephalus and we want to divert CSF. In certain infections, we can drain the infection. In certain instances of ischemic stroke, when someone's maybe swelling their brain, we can consider placement of the EVD. Now, what are maybe some of the contraindications to placement of an EVD? Say if someone has a coagulopathy, of course, we don't want to increase that tract hemorrhage rate. A scalp infection, we don't want to go through an infection that could automatically just cause entry of bacteria directly into the brain upon placement. And then in certain brain abscences, we would not place an EVD, again, for risk of infection as well. So the extraventricular drain is really the gold standard for measuring ICP as well as draining ICP. But I'll mention a little while later that there are other ways to measure ICP, such as optic nerve sheath examinations, transcranial Doppler examinations, even lumbar drainage. But this really is the gold standard. And so we can then drain CSF, we can drain blood or infected CSF products, and we can monitor ICP. So when we put a EVD in, this is the waveform that we're going to get. And I'm going to go over it briefly here and then in detail on the next slide. And so the normal waveform that we want to see is here with a P1, P2, and a P3. And just to introduce this early, but again, we'll go into it in more depth, is this is largely the waveform that we are most interested in not seeing and being able to recognize as a pathology. And this would be here where we have P1, an elevated P2 above P1, and then P3. And we're going to go into this in a little bit. A humorous way that you can remember this is that think that this P2, when it's elevated over P1 and P3, it looks like a middle finger. And just keep that in the back of your mind as we progress to the next slide. So what is P1? Well, think of P1 this way. P1 is when you have blood coming up to the brain, and the first thing that's going to hit is it's going to hit the CSF. And so that's going to give you a certain percussion waveform, and that's P1. Now, the second thing that's going to happen is you can have a tidal wave effect by the CSF coming up and then hitting the brain parenchyma. And this is a really test of what the compliance of the brain here is, and that's represented by P2. And that's why we are so interested in increased intracranial pressure. You have less compliance of the brain, and when that is elevated so high, that's the thing that we're most concerned about with. The last thing here is that P3, and that P3 really represents just the dichrotic notch when the aortic valve closes. So again, this is that P2 waveform here when it's above P1 and P3 that we really want to remember and ingrain in our minds, because if we see this, this is an indication of decreased compliance of the brain and increased ICP. And again, it looks like a middle finger, something humorous to keep in mind so you can remember it. And then lastly, down here, if you were very unfortunate to see this particular waveform, this is what a critical ICP here, when the pressures are so high, you don't even have P1 and P2 anymore. So what are some of the drainage risks? Well, you could have under drainage, and this can result in sustained ICP. Someone would likely have new neurological deficits or a repeat of their neurological deficits, or they've complained of headache, or they'd have altered mental status. And where might you see this? You can see this caused by obstruction of fluid flow, say the catheter is kinked, or say there's debris at the catheter tip, or maybe we put this in because of hemorrhage into the ventricles and maybe there's a clot within the EVD catheter. So again, the presentation would be headache, but think really any neurological decline, altered mental status, etc. Now, this is of concern because in the worst of cases, this could lead to herniation. So over drainage risks continued. These are now over drainage risks. And so over drainage is something that we will discuss in more detail when I talk about leveling the EVD and how the EVD actually works towards drainage of CSF. But keep in mind here that you can have over drainage if the collection chamber draining is at a lower pressure than what, say, was ordered by the neurosurgeon. This will be clearer in later slides. You can have increased ventricular pressures, which causes more CSF to come out. You can, say, have straining with the bowel movement, where you have a big Valsalva maneuver and you increase your pressure in your brain, and you can have more CSF coming out that way. The same thing can happen, say, with coughing, or this can commonly happen, say, with suctioning through an ET tube. So this is something to particularly keep in mind. So again, over drainage risks continued here. Just as with under drainage, you can have headache, you can have altered mental status, you can have cranial nerve palsies, and as the dura moves away from the skull, you can have subdural hematomas, and you can also have what's called hygromas formation as well. So this is a look here at what our EVD system will look like here at Lawrence General Hospital. And we're going to talk about setting up the EVD. Now, of course, we're interested in what the pressure in the brain is. So as with an arterial line, we commonly set the pressure at the level of the heart here. But since we're concerned about the pressure in the brain, we're going to set the pressure here at the level of the ear, right here, at the level of the tragus. And so keep this particular in mind. This is where the EVD has to be zeroed at. So what do I mean by that? Well, here's going to be the 0 point right here on the EVD. And this has to be level with the tragus right here. And so that's the 0 point right here. And then we will move this chamber up and down to determine at what pop-off pressure we will set. And this is perhaps maybe a little bit clearer here. Here again, we're leveling this particular device here to the level of the tragus. And then we move this up and down here. See these black numbers on the side here to see what the pop-off would be. Now, this is a particular important point, and I wanted to show this here now, is that at the current moment here, this particular EVD is open for drainage. And so what is important to keep in mind? What's important to keep in mind is that if there's going to be any patient movement whatsoever, you need to close the EVD off. And the reason why that is let's say if I came in to do an arterial line on the patient, and I asked to raise the head of the bed of the patient up. Well, now I say raise the head of the bed of the patient up high. And in essence, what I've done is I've lowered the 0 point for the EVD, and I could dramatically increase the amount of CSF that's going to be drained. So the take-home point is with any patient movement, or maybe even transport, say, et cetera, to avoid having difficulties with over drainage, we want to turn EVD off. It's also commonplace for most EVDs, unless if we had a continuous EVD monitor, that you'd have to turn the EVD off as well to get an accurate waveform and a more accurate ICP monitoring. So again, this is that very important picture right here. Here is where the EVD would be zeroed right here to the level of the tragus, and we move this particular apparatus up and down. Here, this is set at 10. And so this means that once an individual's pressure reached a level of 10 in their brain, then that would be the pop-off valve. And then you'd start the drain here. But again, this has to be leveled at the patient's head, because say if the head elevated for whatever particular reason, the patient got up, the patient sat up, you raised the head of the bed up 30 degrees, et cetera, or beyond 30 degrees, then that would disrupt the zeroing right here, and you could have a dumping of CSF. And since this concept is just so important, we're going to show one last picture of it here. Here is the 0, and here is an EVD that is set at 0 here, so you'd have a tremendous amount of CSF drainage here. And here we increase the EVD up to 20, meaning that only above a pressure of 20 centimeters of water here would the EVD start to drain. So what determines the amount of drainage? Well, the amount of CSF drainage depends on the pressure difference between the ICP and that height of the chamber that we just showed you right there. And so, how do we determine what initial settings are? Well, we can perhaps maybe set the EVD at a low setting, say at 5. And this is when we want to encourage drainage, say in the treatment of, say, hydrocephalus, or in the clearance of blood or purulent infected material. Or we can have an EVD, say, at a moderate setting, say at 10 centimeters of water. And this is primarily placed as an ICP monitor, and there's some advantage in draining a moderate amount of CSF by placing it at this level. Or we can place the EVD at a high setting, say 15 to 20, let's say 20 here. And we can maybe see this perhaps before an aneurysm is secured, or in weaning, which we'll talk about, how we wean the EVD off for removal. Or perhaps in a posterior fossa mass. And this is an interesting concept to understand, where with, say, the cerebellum here and the posterior fossa here, if we were to drain and decrease the pressure in the higher portion of the brain here, then we can cause a herniation upwards, and that's what we want to avoid. So in terms of concerns for overdrainage, it's important to know how much CSF do you produce a day. And it's approximately, we say, maybe 300 to 600 cc's per day, or approximately 20 mLs an hour. So again, if you consistently drain more, say more than 20 mLs an hour, then you do risk pulling the dura down, causing a subdural hematoma or a hygroma. And again, you can have that feared complication of an upward herniation if you have a posterior fossa mass. Take-home point here again is always clamp the EVD when moving the patient or the bed, et cetera, because you want to avoid that dumping. Or I should say, really in the reverse too, say if you lowered the EVD you could temporarily increase pressures, and this could be important in individuals, say, with critical ICP. So catheter occlusions, again, what do you want to be aware of, and what if the catheter stops draining? Well, you want to look at some of the abnormal physiology that can cause this. You can have an intracranial hypotension episode. Maybe there was over drainage. You want to be aware of that. You can have blood that has now occluded the EVD tip. You can have tissue debris, or in a over drainage situation, you can have the ventricular walls collapse around the catheter. So it's important to know here that if you have the latter three here, say the blood, the tissue debris, you'll really tend to see dampening of the ICP waveform. So keep that in particular in mind, right? And that kind of makes sense, right? Say if you have debris at the catheter tip of the catheter, then you're not able to have those pulsations come back to the machine, and it's not able to pick up what the waveform's going to look like. So removal. Removal can be, somewhat of a complicated topic, and you could actually go straight to clamping the particular device. But since most institutions still do a weaning process, I'm going to talk about weaning here. But keep in mind that you could just go straight to clamping in some situations. And so weaning or clamp trials should not be started, right? Unless if we have, cured the underlying problem for why we placed the EVD in the first place. And so what most institutions will do is will gradually increase the pressure of drainage from, say, 5, or if it was at 10, up to 20 over the course of several days before then being clamped. Now, what you could possibly see is that at some institutions, it could be helpful to consider a CT scan before weaning to assess the size of the ventricles. And then if there, say, is concern, you could repeat the CT scan during clamping or weaning trials to see if the ventricles have increased. And this could be something that could possibly, be implemented. But then for the most part, say if the ventricular caliber, is unchanged, ICPs have not been sustained above 20, and the patient has symptomatically improved, and there's no clinical evidence of increased intracranial hypertension, then the EVD can be removed. So here's a nice summary slide here. I'm just going to take a little time to go through it. So things to monitor and to report with the EVD: the ICP value range, the ICP waveform, any change in CSF color, say if you see blood, or say if it becomes yellowish color, concerning for infection, daily outputs, as well as the range of hourly outputs, and in some institutions, coagulation status, when individuals have EVDs placed and why they're still remaining in. This is maybe particularly important just to make sure that, say, many of these patients are on prophylactic heparin, and we want to make sure that they're not crossing over into treatment dose or higher doses of heparin. So complications, again, to keep in mind: tract hemorrhage, and we can get a CT scan to look at this. Ventriculitis is something that we want to keep in mind. Over drainage, say, again, if someone has greater than, say, 350 cc's of output during the course of the day, leading right to subdural hematomas or hygromas, or that feared complication of upward herniation, or catheter occlusion. And again, if any of these particular things happen, then we want to consult our neurosurgery colleagues. What I do want to mention, as I mentioned before, is that there are other ways to measure ICP and say before an EVD is placed. One particular way is optic nerve sheath examination. And there's a nice video here that you can find that I put out on this particular topic. And so this is something to keep in mind, maybe particularly in the emergency department or ICU settings, again, before the EVD is placed. And here are just some additional resources. I really found the Neuro EM Crit a particular paper here with the link very helpful if you want to look into this topic in more depth. Thank you for your time.